My name is Dr. Gina Higgins, and I'll be discussing today some aspects of the management of obstetrics emergencies in rural and remote medicine. In particular, precipitous delivery and shoulder dystocia will be reviewed. The specific objectives of this topic will be to manage the precipitous delivery, the cardinal movements of delivery, to review the active management of the third stage of labor, to care for 2 patients at once, understanding the importance of this, and also the importance of staff training in NRP. With shoulder dystocia, one of the objectives will be predicting the patient at risk and preparing for the unexpected. Active management of the third stage of labor has been defined for international use as the use of parenteral oxytocin within the first minute of delivery, controlled downward traction or continuous traction of the umbilical cord to assist with the delivery of the placenta, and fundal massage on a regular basis after the delivery of the placenta. These maneuvers have been shown to effectively reduce blood loss and postpartum hemorrhage compared with passive management alone. Shoulder dystocia is an obstetrical emergency. It occurs in approximately 1.9% of births of babies less than 4,000 grams, but up to 5 to 9% of births of those babies born to moms with gestational or other diabetes who are between 4,000 and 4,500 grams. There are a number of risk factors to be aware of when considering the possibility of shoulder dystocia, but it's important to remember that most shoulder dystocias occur in those deliveries with no notable risk factors. Some of the risk factors include previous shoulder dystocia, operative vaginal delivery, maternal obesity, weight gain in pregnancy, diabetes in pregnancy, and fetal macrosomia. It has been questioned over time as to, given the seriousness of this obstetrical emergency, why do we not just do C-sections? Unfortunately, cesarean sections also have their risks versus benefits, and given that shoulder dystocia is a risk but by no means a certainty, it's been shown in studies to not be a reasonable strategy based on suspected macrosomia alone. The maneuvers when encountering a shoulder dystocia can be remembered with the use of the helper mnemonic. The first thing is to call for help. When a shoulder dystocia is suspected, even if it is completely resolved early, that's not a predictable outcome. For that reason, it's important to have as many helpers on the way as possible at the earliest sign of a dystocia. Evaluating for an episiotomy can be done at any stage of the dystocia, and although this will not correct the shoulder dystocia in and of itself, given that the shoulder dystocia is a bony obstruction, doing an episiotomy will give you more room to work. One of the more effective maneuvers is the McRoberts maneuver, during which the maternal hips and knees are flexed and the maternal legs are brought up to the abdomen with an assistant on each side of the woman in ideal situation. Anybody in the room can be recruited to help with this, including family members. This flattens the sacral promontory and widens the pelvic diameter a small amount and can make a large difference in resolving the shoulder dystocia. If this does not work, adding suprapubic pressure to the posterior part of the anterior shoulder, just above the symphysis pubis, can also help resolve this by helping to rotate the fetal plane. The enter maneuvers include the Woods corkscrew and reverse corkscrew maneuvers, during which the practitioner is attempting to rotate the baby away from the symphysis pubis with fingers on the posterior part of the anterior shoulder and the anterior part of the posterior shoulder. If this doesn't work, then the reverse can be done with the fingers on the anterior part of the anterior shoulder and posterior part of the posterior shoulder. One of the next maneuvers is to remove the posterior arm by flexing it in front of the fetus and gently remove it thereby allowing the baby to drop down into the sacral promontory and ideally relieve the bony obstruction in the anterior aspect. Should this not work, getting the woman to roll over onto all fours will do two things. It will widen the pelvic diameter and ideally help relieve the obstruction that way, but it also makes the anterior shoulder what was the posterior shoulder. And although it is possible to have an obstruction on the sacrum, it's less common than that under the pubis. And ideally in this position, the posterior shoulder can be delivered as the anterior. A large part of preparation for the precipitous birth and the possible complications thereof, including shoulder dystocia, involve hands-on practice. So it is recommended that you set up the female pelvic model and fetus in your ER or trauma room and do simulations of a spontaneous vaginal delivery as well as shoulder dystocia. This can be done in groups, or if there are further questions or concerns, or if you just want to wait, then a site visit will be done at your site in the future as well. It's important to work out who will play which roles on your team, to rotate the roles, and to become comfortable in instructing others on the scene for assistance. Don't forget to have a timekeeper and a note keeper.